This is part 2 of the MEC Minute on capnography. So, last month we started the introduction to capnography, and we talked about the physiology of respiration, and we also reviewed the capnography waveforms. Today I want to spend more time talking about the specifics of capnography with certain illness states or disease states, and that's what the focus is going to be on today. But before we do that, just want to quickly go over a couple-minute review of capnography and what it's about. So capnography is about measuring exhaled carbon dioxide, and what we measure, the amount of carbon dioxide that's in the air that's being measured, is really a product of ventilation, meaning how much air we're able to move in and out of the lungs and how fast we're moving air in and out of the lungs, and a measure of lung perfusion by blood. So in order for us to have carbon dioxide to measure, there needs to be ventilation. We need to be moving air in and out of the lungs, and we need to have perfusion of the alveoli in the lungs so that there can be an exchange of carbon dioxide from blood to the air that is then exhaled. So if you increase ventilatory rate, you will increase the amount of air moving in and out of the lungs, and you will dilute the amount of carbon dioxide being delivered. So your amount of measured carbon dioxide, the amount of carbon dioxide per unit of air, will go down. If you decrease your lung volume, if you decrease your ventilation, you decrease the amount of air you move per minute, you will have a greater concentration of carbon dioxide in that unit of air. So your CO2 level will go up. If you look at it from a perfusion perspective, if you reduce perfusion of the lungs, which is primarily what we'll see from a perfusion issue, if you reduce the perfusion to the lungs, there will be less carbon dioxide delivered to the alveoli, meaning there'll be less carbon dioxide in the exhaled air. So if you look at this, the second set of bullet points, if you increase your tidal volume, meaning you breathe more deeply, or increase your respiratory rate, you will have a decreased end tidal CO2 because you have a set amount of carbon dioxide being delivered to the lungs by blood, and as you increase the amount of air in and out of the lungs per minute, you will have dilution of that amount of carbon dioxide, so your CO2 level will go down. The opposite of that is if you reduce your tidal volume, you reduce the amount of air that you move in and out of the lungs per minute, or another way to look at it is reduce your respiratory rate, you will have a greater concentration of carbon dioxide, and your ETCO2 will go up. If you are in a low perfusion state, let's say you're in shock, and you don't have enough blood delivery to the lungs, there'll be less CO2 delivered to the lungs for exchange, so your CO2 level will go down. Easy example there is a patient in cardiac arrest. So if your normal end tidal CO2 is 40, but you're in cardiac arrest with no perfusion or little perfusion of blood to the lungs, there won't be much carbon dioxide delivered, and your ETCO2 will go down. If you increase the perfusion to the lungs, then you may see your end tidal CO2 go up. And that's another example of where your patient's in cardiac arrest, then you provide appropriate interventions. The patient now has normal or return of pulse, return of spontaneous circulation, and your end tidal CO2 may go from less than 10 to 40 or 50. That's an example of where you increase perfusion to the lungs and you see what increase in the end tidal CO2. Just again looking at the waveforms, phase 1 is the baseline. That's the end of inspiration. Phase 2 is as you're starting to exhale and you're starting to dilute the dead space of your mouth with air coming out of the lungs, so you're going to start to see CO2 rise. Phase 3 is that plateau phase, which is that phase of expiration where pretty much everything you're measuring is what's coming out of the lungs. At the end of phase 3, that's what we would call the end tidal CO2 reading. That's the end of your expiratory phase. And as you start to inhale, the CO2 level will drop back down to that phase 1 baseline because now you're inhaling air, which has a much lower concentration of carbon dioxide. Again, quick review of the waveforms. With normal respirations, you'll see normal waveforms, and your end tidal CO2 will run between 40 and 50. If you are hypoventilating, you will see a CO2 drop, and if you're hyperventilating, you'll see a CO2 drop, and you'll see more frequent waveforms, meaning you're breathing faster, you're diluting your carbon dioxide by these frequent ventilations, you're blowing off carbon dioxide, so your CO2 measurement will be lower. If you're hypoventilating, if you're not breathing well, you will see longer waveforms. You'll see less of them per minute or whatever measure of time that you're going to use, and you'll see the CO2 level will increase and go over normal. And then the last one is that bronchospasm, where phase 3 is kind of delayed upstroke, and you get that shark fin appearance, and that's what you'll see with bronchospasm such as COPD exacerbations or asthma, and you hopefully will see that improve, get more of a normal waveform as you treat the patient with the appropriate interventions. Just a little talk now about airways, advanced airways in disease states and capnography. We like to use it to confirm placement of our tubes, whether it's an iGel or an endotracheal tube. And we use it to continue and monitor the tube position, verify that it's in place. And if we don't see a good waveform, or if we see a poor waveform, then we have to worry about tube placement. And I think I mentioned last time that the state now has an expectation as of the 1st of next year, all patients with artificial airways will have continuous capnography in place. So there is an expectation that if you place an artificial airway, such as an endotracheal tube or an iGel, the patient have ongoing capnography, and that the capnography be documented in your run report. Here's what you might see if a patient has a tube in place and then it becomes dislodged. I think this is another good indication of why we need to have capnography. Our patients in the ambulance, our patients at the scene, our patients in the emergency department are moved around quite a bit, and there's plenty of opportunities for us to dislodge a tube. So if you place an endotracheal tube or an iGel, and you need to have them on ongoing capnography, and you need to pay attention to the waveforms, because if you lose waveforms, then you go back to square one and you reaffirm the tube's correctly placed, the patient's being ventilated well, and so on. I mean, you also have to check for mechanical problems like disconnection of the lead to your monitor, but we have to keep that in place, and it is a standard of care. Talk a little bit more about CPR. We talked about some of this last time. Here's a waveform. Patient is in cardiac arrest. You're doing compressions, and you have some bit of a waveform associated with ventilations, but then all of a sudden you see a big jump in the CO2 value. Well, this to me is a good indication that there's now perfusing rhythm. The patients had ROSC. And I use the capnography as a better determinant of ROSC than pulse checks. I rarely stop compressions for pulse checks unless I see a change in end-tidal CO2. In this case, the patient's going from a low end-tidal CO2 to a very high one, and that suggests two things. One is that there's return of circulation, and the other is the patient has had increased amount of CO2 delivered to the lungs because the patient has not or has been in arrest. So you may see a big increase in the CO2 value. So if you look at CO2 values and as a measure of prognostication, patients who have higher end-tidal CO2s during the course of their CPR and immediately upon ROSC, their outcomes or survival to discharge is greater than the non-survivors. So that's why we tend to use end-tidal CO2 as part of our decision making process to determine termination of resuscitation. So patients who continue to have low end-tidal CO2s during the course of the resuscitation have very poor outcomes, whereas those who have good end-tidal CO2s during the course of the resuscitation have a much better chance of surviving to hospital discharge. Talk a little bit about increased intracranial pressure and capnography. If you look at what we've done for head-injured patients over the past 30 years, we've gone from hyperventilating patients thinking it's going to help them with a better outcome to just ventilating them normally as if they were breathing normally. So our goal now is to measure capnography in a head-injured patient and keep capnography levels in the normal range. So if you look at what happens with carbon dioxide in the brain, if the CO2 level goes up, it causes cerebral vasodilatation. So the blood vessels within the skull dilate. And the good part about this is it increases cerebral blood flow to counter any hypoxia that may have occurred. The downside is, though, if you have vasodilatation, it increases intracranial pressure, which can cause worsening brain injury. Keep in mind that these blood vessels are inside a tight, hard skull, and there is no give. So if you have increased perfusion, if you have swollen blood vessels, you're going to increase intracranial pressure, which results in bad or worse outcomes for the patient. On the opposite side of the street, if we have low CO2 levels, we will get cerebral vasoconstriction. The blood vessels will get smaller. And the good side of that is it lowers the intracranial pressure. So if we blow off carbon dioxide in a head-injured patient, we will cause some vasoconstriction and possibly decrease the intracranial pressure. But the bad side is if we cause vascular constriction, then we are going to increase the hypoxia to the brain. So if you look at a high CO2 and a low CO2, they both have good points, but they also have bad points. So our goal is to try to not hurt the patient. So hypoventilation will increase our CO2 levels, and it results in cerebral vasodilatation, which is not good. It results in increased intracranial pressure. Hyperventilation will decrease the CO2 levels in the brain, but it will cause cerebral vasoconstriction, which is bad for the brain. So what are we going to do? Our goal is to avoid hypoxia and maintain adequate cerebral blood flow. We want to monitor oxygen saturation to make sure the patient does not develop hypoxia. And what we want to avoid are the 3 H-bombs of head injury, which have to do with hypoxia, hyperventilation, and hypotension. All 3 of those have individually and independently been shown to be harmful to the brain, particularly if the brain is injured. So our goal is to utilize capnography along with pulse oximetry to maintain adequate oxygenation and hit an end-tidal CO2 target of 35 to 40 millimeters of mercury. And that for us should mean that we don't try to squeeze every bit of air out of the bag when we ventilate the patient. We should shoot for a normal tidal volume, which is 400, 500 cc's of air per compression. It's now advocated that we basically take 2 fingers and squeeze the bag for a second and let go for 5 seconds. So we're going to deliver 10 respirations per minute, and each inspiratory effort, each compressive effort on the bag should last 1 second, with leaving 5 seconds for the patient to exhale. I know some people have advocated getting the BVMs that have the little blinky light on it. You compress or squeeze the bag only when the light is lit. As soon as it turns off, you let go of the bag. And that our goal, again, is to maintain an end tidal of 35 to 40. And if you have inline capnography in place, you should be able to reach that target. How about the dyspneic patient? Well, other dyspneic patients patients that may benefit from CO2 monitoring include the COPDers, asthma patients, patients who have CHF or pulmonary edema, pneumonia, and pulmonary embolism. So the reason we use CO2 monitoring is for most of these patients is to get a measure of respiratory failure. So we use capnography for measurement of CO2. We use oxygen saturation or SiO2 to measure oxygenation. So patients typically have either hypoxemic respiratory failure, meaning they're not getting enough oxygen, or they're having hypercarbic respiratory failure, meaning their CO2 level is elevated because they're not ventilating adequately. So we can use both devices to measure patients' respiratory status. So we like to use capnography on these patients because we can assess the patients for low perfusion status, so shock, We can evaluate them for hyperventilation or hypoventilation. And we can use the waveforms to identify disease states such as asthma or COPD with bronchospasm, and to monitor for improvement in those disease states as we provide treatment. So capnography and bronchospasm, again, the shark fin, we look at for that in phase 3. Here's a normal waveform versus an asthmatic, and it's not always as straightforward as that pretty looking shark fin. If you look at the lower graph, you can see that it does kind of go upwards. It doesn't quite look like a shark fin, but it does have that upward tilt to it, which would go along with bronchospasm. So if we have a bronchospastic patient and we treat them, you should expect improvement. So the top waveform, you can see that nicely defined shark fin. On the bottom waveform after therapy, it's got more of a normal appearance. And you can see this develop fairly quickly as the patient's responding to your bronchodilators. How about the patients with COPD? Well, in COPDers, we can use it to get an idea of whether or not they're bronchospastic, so we can look for that waveform, but we can also get an idea of what their CO2 level is. So we have some COPD patients who are chronic CO2 retainers, and their body with time can compensate. The kidneys will compensate for that chronic CO2 retention by adding additional bicarb to the system. However, we also have COPDers who acutely retain CO2. So the waveforms are helpful because we get an idea of our starting point. Generally, if you have a COPDer and their end tidal CO2 is 45, 50, 55, it's probably chronic, although they may have acute component to it. But if their CO2 level is in the 80, 90, 100 range, they're more likely to be in acute CO2 retention, and they need interventions such as either CPAP, BiPAP, or intubation. So we can look at these waveforms. The top waveform looks normal. The bottom waveform, you have a bit of a shark fin appearance suggesting spasm, but you also see that the CO2 level is higher than we would consider to be normal. And if we're worried about is this retention of CO2 acute or chronic, we can think about their mental status. If the patient is acutely decompensating and their CO2 level is 60 and they have an altered LOC, then they probably have acute hypercarbia or hypercapnia, acute retention of carbon dioxide, and we should be more aggressive in our interventions. So you can see patients with CO2 retention that's chronic. They tend to be alert. If you have someone with high CO2 values and their mental status is impaired, they're more likely acutely decompensating with acute CO2 retention. One other thing on that slide is if the patient's in acute retention and you provide an airway, you would also hope to see the CO2 level get back to a more normal range. We'll give you a quick scenario here. She's got a 70-year-old patient, dyspnea with moderate chest pain. She's had a history of MI, bypass surgery. She's on oxygen chronically. When you arrive, her pulse and blood pressure okay. She's tachypneic. Skin looks cool and diaphoretic, and she's got edema. Her end tidal CO2 is low at 20, and her O2 saturation is low at 79. So you think this patient then, from my perspective, most likely is in CHF, has pulmonary edema. Her vital signs showed hypoxia, so we'll start her on some supplemental oxygen. Our protocol calls for nitropase, which will apply. And if you see that her CO2 level is low, which suggests that she is hyperventilating. Keep in mind that often our patients will have trouble with oxygen and oxygenation before they develop trouble with CO2 retention. So in this patient, she was compensating for hypoxia by hyperventilating or breathing faster. That results in carbon dioxide being blown off. With treatment, you can see that her end tidal CO2 levels have improved. It's rarely this dramatic, where you have 5 or 6 respirations and you're back to baseline, but just as a graphic representation, you see it here. So the patient's CO2 level has improved, gone back to a more normal range, which suggests that her pulmonary status is improving, particularly when you compare that to a normal O2 saturation as well. So it's an example of a patient who's hypoxic, but hyperventilating, they're blowing off carbon dioxide, their CO2 level returns to more of a normal value with appropriate treatment and intervention. Here's another scenario. A 25-year-old female, acute shortness of breath with sharp chest pain. She has no health issues in the past. She's on medication for smoking cessation, and she's on hormones for birth control. For me, a tachypneic female on birth control pills with sharp chest pain is a pulmonary embolism until proven otherwise. So what might we want to or expect to see on a end-tidal CO2? So, thinking of pulmonary embolism, you've got this ventilation-perfusion mismatch, and we talked about that last month. Meaning you have a section of the lung that is receiving air, so air is moving in and out of the air sacs or alveoli, but there's no perfusion to that area, there's no blood supply to that area because there's a blood clot in the way that's keeping blood from getting to the alveoli. So you have a normal tidal volume, a normal amount of air moving in and out of the lung, but a reduced amount of carbon dioxide being delivered to the lungs because of this pulmonary embolism. So you have dilution of that CO2, you have less CO2 per unit of air, and you're going to expect to see a CO2 level that's low. And that it's another way to say it is you have increased dead space in the lung, which means we have increased area of the lung that has air in it but is not getting blood. So this is what you might expect to see in a patient with a pulmonary embolism. The patients could be hypoxic, they most likely will be tachycardic, and their CO2 level can be low because they just are not perfusing a significant portion of the lung. So an example of how you could use capnography to support your concerns or support your impression that this patient has a pulmonary embolism. How about for hypoventilatory states, patients just not breathing well? Well, you can see this in any patients with altered LOC, and that could be from a head injury or a stroke. I think for us, drug overdose is the most likely cause in the field. In the emergency department, we worry about hypoventilation in patients that we have sedated. So if you look at our process, when we sedate patients to perform a procedure such as reduce a shoulder dislocation, we use capnography to monitor the patient's respiratory status because capnography is going to be more sensitive indicator of hypoventilation than pulse oximetry. Typically, it will take in a normal patient 4 to 7 minutes to become hypoxic with sedation, whereas if we overly sedate a patient, we will see change in waveforms on capnography almost immediately. Alcoholism, patients who are severely intoxicated can also have an altered mental state and be hypoventilatory, particularly if the alcohol is mixed with other drugs such as Valium or benzodiazepine. And then we think about what we could see in a patient who is septic or has an infection, particularly if patients had altered LOC, which could also indicate like a meningitis, but you don't have to be suffering from meningitis to be altered LOC from an infection. And we see that in the elderly patients that are elderly with altered LOC that turned out to be infected either from UTI or pneumonia or septic from an unknown source. So what do we see in patients who are hypoventilating? Well, which waveform do you think it is? Well, it's option C, because you have slower respiratory rate, you have longer breaths, and your CO2 level is elevated. It's over 45. So the top chart, the patient's hyperventilating. The middle chart, they are normal, and the lower chart, if you look at the curves are long, drawn out, and they're above the normal value. So those are the patients that are hypoventilating. How about this patient? This is a nursing home patient. You approach the patient's on an oxygen mask, and his chin is on his chest, and you put capnography on him. What do you think about this patient? So is he ventilating normally? Well, his rate may be normal, his CO2 may be normal, but if you look at him, the waveform really never goes back to baseline. So the patient's got kind of a pinched airway, and he's not positioned well, and he's basically rebreathing his own carbon dioxide. So if you open up his airway, allow him to get rid of, or have a normal airway, you may see that the waveform gets back to normal. How about DKA patients? How could we use DKA, or how could we use capnography to evaluate our DKA patients? So how do DKA patients breathe? So, keep in mind, a patient who is in DKA, their blood sugar is elevated, their body is starving even though there's plenty of sugar around. So the body just can't metabolize the sugar because it doesn't have the insulin necessary to get the sugar into the cells. So the body is going to go to an alternate method of metabolism that's going to form ketones or keto acids, which results in a metabolic acidosis. So your blood, or the patient's blood, becomes more acidic. Well, our body only has two ways to adjust its pH. One way is by adjusting our respiratory rate. The other way is by the kidneys either adding or removing bicarb, but the kidneys take days to compensate. So in a patient who's acutely acidic, the body's only ability to respond to that acidosis is to breathe faster. So DKA patients tend to breathe deep and fast. They're blowing off carbon dioxide to help counter the acidosis. So how about patients in shock state? Well, perfusion is one of the two components of determining an end-tidal CO2. So when we measure end-tidal CO2, in part we're measuring perfusion. So patients who are not perfusing well, we will start seeing changes in their CO2 value. And typically what you'll see is a drop in end-tidal CO2. So if you're not perfusing the lungs, you're going to see a drop in CO2 regardless of what the patient's ventilatory rate. So perfusion is something we can measure by using CO2, and that's important in trauma patients, patients who may be in cardiac arrest, or in any other form of shock, such as patients who may be septic or may be bleeding out from a GI bleed. So always think about perfusion states. When to use capnography? Well, think about it for STEMI patients. Think about it for patients in cardiac arrest. Think about it in patients who are being sedated or who are on meds for analgesia. So if you're giving a patient a big slug of IV fentanyl, think about placing them on capnography. If you have a patient that you're going to sedate with intravenous ketamine, place them on capnography, because it's a good way of determining whether or not the patient is becoming depressed from a respiratory perspective. Keep in mind that some patients with IV ketamine may suffer a respiratory arrest, so capnography is important. And to think about using capnography patients who have infections, who may be intoxicated, who may be hyperglycemic, including DKA, and any patients with the potential for increased intracranial pressure. So it's one of those things where if you think the patient may need capnography, just go ahead and do it. Put it on the monitor, measure their CO2, and document it in your record. So that's all I have for capnography. That's the end of the two-month series. If you have any questions, please pass them on either to me directly via email or post it on Workplace. Thank you.